All, this is Dr. Mobeen Sayed from Drbeen.com. Welcome to one more show. The session today is a follow-up to the discussion yesterday about the UK's Public Health England's data and the my demonstration of the data from Office of National Statistics. Some of the folks who were commenting in there, the comments were something like, number one, why are you showing ONS data while we are talking about public health data? And the public health data is not something that I'm showing. So some comments kind of made it look like if I was deceiving. So I would explain what I was showing, and I would actually show you an email as well from Public Health England, also referring me to the same links. Second kind of comments that I saw were the death rate per 100,000 and that not computing. And that is correct, that on the Excel sheet that I showed, if you do a direct math of the death rate, it does not compute. And I would explain why does it not compute. Some of the folks in the comment thought I had tampered with the sheet. So I'll show you the sheet. It is the same one. You can actually download it from the link I showed yesterday, and you can compare it. But I would also explain why the data is not directly just calculable. With this, most important thing that I want to do is I reached out to Public Health England and I said that you've been putting these numbers out. What is your explanation of those numbers? And they have responded. Luckily, they responded within 1 day. By the time I got up this morning, I had the data or the response. Their auto reply had said they would respond in 18 days. However, they had taken up my email quicker. So thanks to Scott from Public Health England for responding quickly. So with this, start a discussion. I think you would like it. And once again, the point of is not to say you should go take. Here is how they are the agencies, the administrations, immense of them. You could totally, it does not mean that way for me. And that is fine. That is your opinion, your interpretation, your understanding. So let's use this more of a discussion compared to just quarreling. I think that is counterproductive. So let's start. Okay, so this is drbeen.com. Then here is let's start actually from the Public Health England's response. With that response, then I can show you various references. So here, what I did was I had reached out to them, and I said that your technical briefs have for Delta variant, for example, they have the number of cases and then the number of deaths, and the deaths ratio, cases to death ratio, is higher vaccinated compared to unvaccinated, and that ratio is then taken up by various folks, and they are claiming that vaccination is causing a higher death rate. And I said, you're causing confusion with those numbers. Can you tell us more? So here is what they responded. This is Scott from Public Health England. This is, as you can see on top of it, it says official. So I think that they do not mind me sharing it here. So they said, Dear Dr. Mobeen, thank you for your email to Public Health England dated 14 September 2021 regarding your queries on our COVID-19 technical briefing. I work on the team that handles inquiries and have been asked to respond to your request. And the response here, I'm going to illustrate that as well, but let's read that. And the good news is that this link here, deaths involving COVID-19 by vaccination status, England death occurring between 1 January to 2 July, and the Office of National Statistics, this is the exact data and the link that I was using yesterday. The reason for me to use this was the following. The Public Health England's data that I'll show you in their technical brief in a minute, that data is the absolute, these many cases of people who were vaccinated or not, cases of COVID in people vaccinated or not, of Delta or Mu or other viruses, so many deaths. So these were just plain raw numbers. But to make sense of those numbers, one has to look at the so many stratifications. For example, we have to see the population sizes in both groups. We have to stratify for the age, for example. We have to compare similarly aged folks in both groups and see the death rate in them. We have to see the comorbidities and stratify for that, and so on. So it's not just a simple straight math to say divide this number by this number and here is the answer. So they actually sent me to the same place because ONS is providing data with that context, with the stratification. And you and I cannot sit here and do that stratification because we do not actually have all that data. For example, if we say that in this week, unfortunately, 20 people died of COVID who were vaccinated, 10 died of COVID who were not vaccinated. What we do not yet know, the ages, the comorbidities, immunocompromised or not, diabetic or not, and so on. So ONS, when they look at the data, they stratify it. So anyways, public health, then Scott sent me to this data. And let me just show you a couple of things here. One is in this paragraph at the top. They're saying in the context of very high vaccine coverage in the population, let me see if I can make it a little more. In the context of very high vaccine coverage in the population, even with a highly effective vaccine, it is expected that a large proportion of cases would occur in vaccinated individuals. And to understand this, if everybody is vaccinated, then any cases that would occur will occur in vaccinated. And if no one is vaccinated, then any cases that would occur will occur in unvaccinated. That's just using the extremes to explain this point. Simply because a larger proportion of the population are vaccinated than unvaccinated. This may be even more notable. So this is a very important point. If vaccination has been prioritized to individuals who are more susceptible or more at risk of severe disease. So in majority of the societies, communities, what happened was folks who were vaccinated first were those who had advanced age, had comorbidities. So they were vaccinated first. So if you compare their situation to, let's say, youngsters, that does not work very well, even if the youngster is unvaccinated. And that is what I mean by age stratification. And I'll show to you, this is not my opinion set today. This is really just showing the data and how they come about to that data and what way is it that they are looking at it. You could say, I don't agree with them. Totally fine. So this is not my opinion set today. Okay. Then they say, this may be even more notable if vaccination has been prioritized to individuals who are more susceptible or more at risk of severe disease, as in the United Kingdom COVID-19 vaccination program. In particular, when looking at severe disease outcomes such as hospitalizations or deaths. Then they make one more point. Individuals in risk groups may also be more at risk of hospitalization or death due to non-COVID-19 causes, and thus may be hospitalized or die with COVID-19 rather than because of COVID-19. Then they say the Office of National Statistics published data on 13 September that might be of interest to you, and they sent me to the link that I had actually shared yesterday. I'll share that link again here. And then Scott was kind enough, he said, I've copied table of 5 below for the case of reference. This is a very, very important table. Yesterday, I showed a diagram below, I believe, this table, but it was on the same link. Actually, let me show you that link here as well. So if we go here, I think this is the one, yes. Somehow this page always refreshes when I So if I go down here, one thing to keep in mind is this point number 4 over here that says age standardized mortality rates for death involving COVID-19 by vaccination status of over time. I would explain what age stratified numbers mean. But if I go down here, you would see this is the table that they referred me to. If I continue to scroll through this, let me use the thumbnail, you would come across, this was the diagram I showed yesterday, and I had said that I took data from this link. This link is present in the description. You can actually just go to this link, this is an easy table to find or graph to find on this page. It's the only one. And then you can go down here and download this data and confirm that the data that I'm showing is the same that is here. Anyways, going back here, this is important to look at this table. So this one. This table says, now what is the difference of the data here compared to the data with the Public Health England? And let me just very quickly flash the Public Health England's data as well. So this is the email, but if you see here, I have their technical briefs open. Some folks thought that I was being deceptive yesterday to not show this table. And a few weeks ago, I had actually looked at one of the briefs and presented a detailed analysis of this table. So I didn't think we needed to go over that table again. So let me just show that table here. This is the table. For example, here, let me just make the case for why this confusion is occurring. The important thing to note here is that this is the raw numbers. For example, Delta cases. Over here, it says attendance to emergency care and death of sequenced and genotype Delta cases. So this is not all cases, only those cases that were sequenced whose genotypes were seen. Otherwise, you can see that, let's say from February to 29 August, there are not just 500,000 deaths or cases, sorry, there are millions and millions of cases. Even if you count and sum all of these cases here with all the viruses, they would still not appear to be fully jiving with the other actual number of cases. That is because this is not a thorough data set. This is, they say it over here, sequenced and genotyped. And here, the second thing, if you look at this, I'm only going to look at these right two columns. Lesser than 50 years of age, for example, fully vaccinated had 62,403 cases of infections. And then with Delta variant, and then greater than or equal to 50 years of age had 51,420 cases. Total vaccinated folks had 1,113 cases. And this is the unvaccinated 212,989, lesser than 50 years of age, and 6,724 greater than 50 years of age. And this is not because somehow folks who are greater than 50 years of age and are unvaccinated somehow have a power that they cannot be infected. And that is why the number, if you compare that, 6,000 to 51,000, this is just a population size difference. The folks who are greater than 50 years of age, very few of them are now unvaccinated. That is, very fewer of them have the infections. But if I continue to go down here, this is where the death rates are. Or sorry, not the rate. These are the absolute numbers. So if you see here, the last two numbers, this is vaccinated, less than 50 years of age, greater than 50 years of age, 1,000. So what does this mean? 1,000 vaccinated people. Out of 51,000 vaccinated cases, 1,000 died. But out of 6,000 vaccinated cases, unvaccinated cases, let's 437 died. So if you look at the overall numbers, you would see that people who died in vaccinated are more for the cases compared to unvaccinated. This is the table. Some folks thought that I was not deliberately showing it. I thought because I had done a complete analysis before, that's why it was fine. And I wanted to show the Office of National Statistics to show in context. So let's go back to that table here. This table doesn't talk about genotypical data or phenotypical data. It talks about all data. So let's see. All deaths, regardless of vaccination status, 51,281. This is from 2 January to July 2. Non-COVID deaths during this time, 214,000. The percentage of COVID deaths to the non-COVID, 19.3%. Unvaccinated folks from, again, 2 January to 2 July, unvaccinated had 38,964 deaths. Non-COVID, 65 in unvaccinated. So 37%. If I go down here to deaths 21 days or more after the second dose, 458. And please, there are going to be folks who would just now accuse me that you skipped deliberately some rows. You can look at them as well. You can call them vaccinated if that helps you make your case. I want to see fully vaccinated folks. 150 to 38,000 deaths. But there is still a piece that is missing. Non-COVID related deaths, 57. And so overall in vaccinated population, COVID related deaths have dropped to 0.8%. Compared to folks who are not vaccinated, in them, whatever are the reasons for death, there are other reasons as well, plus COVID. COVID is still a big reason for death in unvaccinated. So this is where they sent me here. So they actually copy pasted that over here, Scott. Then he says, additionally, here is a link to all of our technical briefings, and I have downloaded some of them, but this is the link he sent me for their all technical briefings. So if you go down to the bottom of this is somewhere in December. So I downloaded this one as well. Somewhere in December of last year is when they started these technical briefings. They have some data downloadable with that as well. That data was pretty much not useful because it is similar data that is shown in the tables in the tech briefing. So one, I'm grateful that they responded. I have asked them some more questions as well. But now let's go back to this question that what is the difference of the data in public health and versus ONS? So I want to show you one more area now, and that is if I scroll down on the ONS. So let me back up for a second. So I hope that this case is clear, that when we want to see data in context, stratified for age, stratified for comorbidities, then it is important to look at data with population sizes, with comorbidities, stratified together. And that is not what Public Health England's data is. They are giving raw numbers for variants. Here, if you wanted to see the data in context, for example, if you said people who are 70 years and over, who are vaccinated, and let's say they are 1 million. I'm making up a number here to give this example. Compared to people who are 70 years and over, unvaccinated, maybe they are 100,000. And if we look at the infection rate in them and death rate in them, we stratify them, and then we compare them. What does that mean? If we look at that kind of data, which is the right way to look at data, then this sheet that I had shown yesterday is the one that works. Now, in this sheet, there are certain things, many folks pointed it out in the comments that, hey, the numbers don't add up. So some folks thought I had let me see if I can increase the size of this sheet. Okay. So here, let me show you. For example, if you look at July, this was the most common commented on. July, 2nd July, number of deaths in unvaccinated, 35. Unvaccinated population, 9.5 million. Death rate is 1.6. And so this is where people thought I had actually changed it. Let me explain what it is, but first let me explain what is the problem here. The problem is, if out of, let's say 10 million, if out of 10 million, 35 people died, then the death per 100,000 is not 1.6, it is different. And if the death rate is 1.6 per 100,000, then the number of deaths should have been somewhere about 16. So folks pointed it out and they said, hey, the numbers are off. And did you mess with them? Now let me go to how to look at these numbers. And again, these are not my made up numbers. I'm just trying to make sure that we cool beans have looked at these and we understand where the numbers are coming from or how they are working on them. So once again, Office of National Statistics, I believe at the top here, age standardized mortality rate. Age standardized mortality rate. Now, what is that? Here is WHO talking about age standardized mortality rate. What they're talking about is the following. And these health agencies, they use WHO's definition of and the process of creating age standardized mortality rate. What does that mean? In rough terms, with various ages in them, with various comorbidities, with various genders. And let's say out of that whole population, 10 people die of some reason. And we want to compare that 500,000 population to another 500,000 population being treated with some medicine. The other 500,000 is not. If we just simply take the death or incidence of something, if we just take events in 1/2 million, let's say 10 over here, and just simply divide them by 500,000, then it is possible that the comparison will not be correct to do to the other side if the age, let's use one factor, age. If the age is different, let's say, just to make the point, this 500,000, let's call it 500,000 A, they are all above 70 years of age. And we are comparing them to another 500,000 who are all below 10 years of age. I'm deliberately making up such an extreme difference to explain what is happening. Now that comparison, for example, in case of COVID, is not a fair comparison because children lesser than 9 years of age actually handle COVID without any even symptoms. On the other hand, folks in advanced age or with comorbidities may have difficulty to manage COVID using their own immune systems. So what WHO says is that, hey guys, don't do this crude raw division and compare them. Instead, take the age and stratify that and then compare them. So that means if we take this guidance, then these two groups cannot actually be compared because one group is all 70 years and old, other are all 9 years and less. They cannot be compared. So what you do is, normally, of course, populations are not that way. So what you do is you take the 70 plus from group A, you take the 70 plus or similarly aged folks. Best analysis is if 1-to-1. You take all 70 plus from this, and you take all 70 plus from the other group. Then you match them one-to-one to closest age, comorbidities, and so on, and then create a comparison. That is impossible to do in larger scale. So then what they do is they have statistical tables to say at this age group or in a community, we can have this breakdown of age as a standard breakdown and then compare. So here, if you see, WHO says age standardized mortality rate. It is type is rate, topic is mortality burden of a disease. The number of deaths per 100,000 population are influenced by the age distribution of the population. Two populations with the same age-specific mortality rates for a particular cause of death will have different overall death rate if the age distribution of their populations are different. Age standardized mortality rates adjust for differences in the age distribution of the population by applying the observed age-specific mortality rate for each population to a standard population. So this is how WHO guides it. And I was reading Public Health England's data, and they said we use, and even for ONS, they said we use this definition and this method of age stratifying. I have this link in here as well. Here they have, this website is a good website for medical students. They have done an age stratification process with an example. So if you wanted to see a worked example, you can see that over here. Now, if I go back to this sheet, what they are really doing is they are comparing unvaccinated with vaccinated. And even when they say there are 35 deaths over here, they are picking up the folks who can be matched to the other group, and then they're picking up from the other group the folks who can be matched here, and then comparing their death ratio, and then coming back and saying, okay, this is the kind of number. That is why there is a confidence interval. If it was a straight division, then you won't have a confidence interval. There is no confidence interval needed for a straight division. You don't divide 4 divided by 2 equals 2 confidence interval from 1 to 5. That's not possible, right? That's just 2. But here, because there is a statistical process applied to it, then they have a confidence interval to say lower limit this, upper limit this. So this is just an explanation of why the math, when some folks did, why did that math? For example, if you see here, this is now vaccinated second dose folks, 2nd July, number of deaths, and the 100,000 per 100,000 rate. So if you see here, if we look at 0.2 per 100,000, that means 1 death per 500,000, correct? And here, that means 2 deaths per million, and 23 million multiplied by 2 is 46. So this number and this rate does not work. And once again, that is because it is age stratified, and they actually talk about it. If you go down here, they say notes, age standardized mortality rates per 100,000 people, standardized to the 2013 European standard population using 5-year age group from age 10 and over. For more information, see our methodology article. So if you wanted to see how did they calculate this, it's not a straight division. You could go to this article and see how did they use that process. Again, the reason, if you look at this whole talk today, I'm not sitting here to say vaccines are working or they're not working. I'm just trying to present the data, that when we look at data, this is how the data structures are, the processes around this. We are, at least I'm not a statistician, so I was not interested to go and see what is the process. If you are a statistician or if you are interested, you can actually do further digging and read and understand how they're stratifying. This stratification happens with studies as well. When you're comparing two groups, you try to keep those cohorts as similar to each other as possible. And even if they're not, you try to then stratify afterwards to compare them as closely as possible. That's a similar thing over here as well. So with this, I'm gonna now quickly go over. So I hope that this one thing is clear, that in unvaccinated folks in the UK, again, they're not comparing them to vaccinated, because once again, that comparison does not become correct. Why? Because the group types are different. So until you stratify them, you cannot compare them. Here, what they're doing is this. They're saying, out of all deaths in unvaccinated, what is the proportion of deaths because of COVID? That is 37.4%. And out of all deaths in vaccinated, what are the number of deaths because of COVID? And that is 0.8%. That is how you look at the impact of the vaccine or not. There is still more dimensions to look at. For example, you could say a youngster with or without vaccine, how are they doing? Children with or without vaccine, how are they doing? People with diabetes, how are they doing? People with immunocompromise, how are they doing? And some of that data is actually present. If you go here to the bottom of this page, you would see that they have actually talked about various, so data coverage is here, definitions of immunocompromised. So they talked about the stratified with the immunocompromised, and they have defined what that means, and so that they can compare use of death occurrences rather than registrations. So they've explained every single data point, that how did they use it and what does it mean. They have defined what death means. They have defined what positive case means. They have defined what vaccination means, and so on. So they've done a good job here. Now I'm going to go back to just once again this quick chart over here. This chart, I would request you to look at it. It is an interesting number to look at. And then this table here is also interesting, because what they're doing is, in this table, they are showing the vaccination and unvaccination, not vaccinated, and then male, female, vulnerable, not vulnerable, long-term health problems, not long-term health problems. You can actually see how various stratifications are done and what their difference is. For example, here they say not immunocompromised, 219, this and this. Now, finally, I can't live without showing you my illustrations. So here are my apologies if I'm going to waste your time now, but I want to show you my illustrations. You are cool beans. So there were questions yesterday like the data is off, or the data set, I used a different data set to explain and I was somehow being deceptive. So this is the illustration of the email message by Public Health England by Scott. So one point he made was, the population, as it becomes larger and larger, vaccinated population, of course, more and more cases will be there. I think this we all have talked about many times. Expecting that the cases will not occur in vaccinated is incorrect. Now, will there be some vaccines in the future that would prevent that? Maybe. At this time, these vaccines don't do it. But still, as you saw in the data, 37% part of deaths in unvaccinated versus 0.8%. That's a huge difference. So one difference. So now we're talking about absolute numbers, raw data, and why that is not comparable. One, the population size is different. Then prioritization. So more folks at risk have been vaccinated, and lesser folks who are unvaccinated have those at risk. There are still those who are there. I had discussed that in the last time when we said 50 plus. In there, I discussed various ethnicities and their percentages at higher ages. And I was surprised that, for example, Pakistani folks, advanced aged, were not very keen on vaccination, and they were really low in vaccination numbers. And similarly, religions, so they had all that data available. So prioritization was given to those who are at risk and they are vaccinated. That means they're still vulnerable. And so the death ratio has gone really down. A good way to compare them would have been to compare them to last year. The problem is last year we had Wuhan and Alpha variants. They were not as efficient in terms of causing damage and as fast as Delta. So this comparison from this year to last year is also kind of not the right comparison because of the um, variant. Even if you said, let's just not compare vaccinated, unvaccinated this year, last year, or vaccinated this year to last year, the virus types have changed. So anyways, the second point is prioritization. The third point was more at risk people who are vaccinated, they are more at risk of other diseases as well. They're probably going through some of those diseases actively as well. And so they get hospitalized too. Some of them would die because of the other diseases too. Some of the data that Public Health England had and the ONS has, in that data, they had actually defined breakthrough cases. They had looked at the death cases and said, out of all the deaths, what are actually because of COVID? And I believe that number was somewhere about 252. And then this point I just made before as well, data needs stratification for age, comorbidities, etc. So these are a few of my illustrations. That is the discussion for today. I hope I was able to clarify a couple of things. And that is, and I know that my voice and audio has a lag. That is because of my devices here. So I should use OBS more often because I can fix for the lag. So my apologies if you see that lag. I hope that I could at least present this much. Again, today there was no opinion of mine. This is what Public Health England's response was that I illustrated and discussed with you. Plus, they also sent me to the same link where I had gone yesterday. So that is more of a clarification that why did I want to have stratified data in front of us instead of just the raw numbers and start dividing them without much context. If you divide those numbers and then compare them, there is actually no possible comparison to do that way. So with this, I hope it makes sense. So I will start using, Lizzie says that no wonder the lag. So Lizzie, what happens is that the audio device is coming in faster and the camera's input is going through a device that is converting that to a USB input and then sending that to the computer. Then computer is processing that bigger 1920, 1080 or 4K video to then relay it. And so there is a 200 millisecond difference, and that shows. OBS can fix it. I just did not use OBS. Sometimes it slows down my computer. So this is the discussion for today. I hope you're all doing well, and I would, let's do a quick, if we have questions about this topic, I'm going to come back in a few minutes, and let's have those questions discussed there. And finally, if you like these talks, please support them. There are 3 links in the description. You can buy me a coffee, or you can use PayPal, or you can be a patron. Thank you very much, and I would see you in a few minutes.